Good afternoon, everyone. My name is AC Locklear. I am the Interim Chief Executive Officer of the National Indian Health Board. I am a member of the Lumbee Tribe of North Carolina, and just thank you all for joining us here today for this session. Enhancing well-being for Indigenous populations requires not just understanding the distinct needs, but understanding how history, colonization, assimilation, and termination policies of this country has led us to where we are today, and how it continues to impact the lives of our people, and the strength and the resilience of our communities continues to demonstrate even in the face of such injustices. So when we think about what health equity means for American Indian Alaska Natives in the United States, we must consider what those Indigenous determinants of health are that can lead to tribal health equity. Approaching tribal health equity for American Indian Alaska Natives will always look a little different because of the government-to-government and the sovereign status of the United States tribes. As sovereign nations, the federal government holds a trust responsibility and a unique legal obligation to provide health care for American Indians and Alaska Natives. As a result of the treaties that were signed, tribes gave a lot of their lands and other rights to the United States and paid in full for their health care. The Indian health system is unique, and it is comprised of three primary parts: the Indian Health Service, tribal health programs, and the urban Indian health programs. This is commonly known as the ITU system. Tribes can choose to have their health care provided by Indian Health Services, or they can choose to take the path of self-determination and contract and compact to take on those services themselves, or they can seek the services through urban Indian programs. Unfortunately, the Indian health system is chronically underfunded. Tribal budget formulation estimates the full funding need for Indian Health Service to approximately $63 billion. FY24 funding for Indian Health Service was only $7 billion. Therefore, tribes have to utilize innovative approaches and practices to ensure they receive quality health care. Today, this discussion will examine effective approaches and practices that can be employed to enhance partnerships between healthcare providers and Indigenous communities. I will now turn it over to our esteemed panelists to provide a short introductions of themselves. Panelists?
Sheikh Clowett. Sheikh Clowett. Inknash Waniksha Estakio, Washnash Yakama Kanik, Kumashika Kanik, Kutolteka Kanik, Kutlatwani Kanik, Astla Nashwa Kush Ichwi wa In Mitatawat, Divani, Tichampa. Makwalihi Hualacan, Nenotoka Estakio, Amoni Kochi, Inmita, Nitzita, Intlaka Nitlatoa, Cuatlanushamash, Tlazokamati. My name is Estakio Beltran, and I serve as Partnership Advisor in the Office of Strategic Partnerships at the Department of Interior. I'm really grateful for the opportunity to speak here tonight and to highlight some of the opportunities that exist to partner with Indian country and to showcase really how we can help our relatives improve the health of not just our communities, but ecosystems around us.
Good afternoon, OCO. My name is Robyn Sunday Allen. My Cherokee name is Akti Godawas. I was born and raised in Cherokee Nation in Northeast Oklahoma, where my family still resides. I am currently the CEO of the Oklahoma City Indian Clinic, which is the largest urban Indian organization in the United States, part of the ITU system that AC talked about. And I am also the president-elect of the National Council of Urban Indian Health, which provides legislative oversight and policy work on the Hill for the 41 urban Indian organizations across the United States. So it is a pleasure to be with you today, and I look forward to hearing your questions later.
Anko, ki onde da, onde basam. So thank you for letting me greet you in my Kiowa language. My name is Jim Kennedy, and I am from the Kiowa tribe here in Oklahoma. And I'm a emergency physician, public health physician, working in Indian health here in Oklahoma at the state capitol and occasionally in Washington, D.C. I also am a member of the board of the Oklahoma City Indian Clinic. I'm the current president of the Oklahoma College of Emergency Physicians, and wear a lot of hats, so get around a lot, do sports medicine, and work for the Mercy Health System, work for the Chickasaw Nation Medical Center here in Oklahoma, as well as the Muskogee Creek Community Hospital over in eastern Oklahoma. So thank you for having us.
Thank you. So, Dr. Kennedy, I'll start with you. What are some of the innovations emanating from tribal nations that are addressing specific health needs of Indigenous communities?
Oh, thank you for the question. We could talk all day about that, but my career, I work primarily in treatment of medical problems in hospitals. So I work not only in non-native hospitals, but in native hospitals as well. And most of my career has been dedicated to treatment of medical problems. But mid-career, I started realizing there's a whole lot that goes on with our patients' health. It has nothing to do with the hospital, clinic, pharmacy, medications, insurance, things like that. So I went back to school and did a Master's in Public Health and a Health Policy Fellowship. And I've been flexing those muscles ever since I got out of my program to do more than just treat the individual medical problem at each stage of the game. And been working with my tribe, working with the Indian communities, Indian organizations, health organizations, both locally, tribally, and nationally, and actually internationally with some Indigenous physician associations. So when you're dealing with Native health, you really have to really understand the nature of what has happened to Indian people on a deep, deep level. And it's really, you really have to start at the beginning. Like first of all, you have to realize these are the first peoples of the Americas, right? So we've been here, probably we can prove pretty much about 25,000 years, which is about 99% of the time there's been people walking around here have been only Indigenous people and no European or any other people from any other part of the world. But most Americans right now cannot tell you they know a single Native American person. Oklahoma, you're more likely to meet one in Oklahoma because we have a higher per capita population of natives than any other place outside of a res. But yeah, that's pretty profound. You think most of the people that have been here for most of the time have been completely marginalized and pushed to the armpits of the country. And most people don't even know a single native and don't know much about native history. So our story doesn't get told very often outside of our own echo chambers. We need to really get our story out to people hear. This is a profound story. It's the story of America. And my colleague, Jim Warren from Oglala Lakota, he's got some great stories. And we have our own stories here in Oklahoma, but a lot of sad stories, but you really have to understand those stories deeply. And so what we're trying to do innovation-wise is not only focus on medical treatment, which is very, very important to insurance and have medical treatment, access to medical treatment, but to try to heal the deep cultural wounds of the natives. And you really have to understand the history to be able to do that and understand that many natives are stuck. You guys are all familiar with Maslow's hierarchy of need, I'm sure. Yeah, a lot of our native people are stuck on the first and second rung of Maslow's. They're trying to find, just basic physiologic needs and food, shelter, safety, things like that. You really can't go up Maslow's before you're stuck on the bottom rungs. So some of the things that I can talk, there's a lot of people who have a lot of projects going on. Specifically with me and my people, we are trying to heal our people by giving them back what they've lost in colonization, which is they were really made to feel ashamed of themselves and that they were less than human for being natives. We weren't even considered citizens of these lands until 1924. We've only been citizens of these lands for 100 years, about 65 years after the freed African American slaves. So that's a really interesting story that was kept that way for so long. But they made people ashamed. So they tried to whitewash the entire native culture, the family. They came in and basically said, okay, we live here now, and you need to do what we wanted you to do. So they took away our language, took away our culture, took away our song, took away our dance, took away our sense of belonging, sense of power, our lands, not just our lands, but our self-esteem and we were fiercely independent people before colonization, and we were made to be utterly dependent in the course of about 10 years. When we wanted something before, we needed something, we went out and made it happen. We needed food, we needed shelter, we needed a home, we needed whatever we needed, we made it happen. And then the government completely took that away through U.S. federal policy and made us utterly dependent upon the federal government. And we were starving to death, and we were depressed, and alcoholism came in, and depression set in, and lean, healthy, athletic Native Americans started becoming obese and started developing hypertension and diabetes, where there was very little of that in the population before. So what we're doing in my tribe and in southwestern Oklahoma, we're doing some things to try to go forward. We're going back. We're going back to who we are. When you go to anybody ever been to a Native cultural event or a powwow. Anybody ever been? Okay, good. That drum is really important to Native people. When you hear that drum, it just really sets something off in your soul. The drum's meant to be symbolic of the human heartbeat. It's one of the most primal, the first sounds we ever heard in the womb was the drum. And the drum is central to our song and our dance and our telling our stories. So we're really trying to go back with, in my own tribe, we're trying to bring back our buffalo. We're bringing back the horse culture. We're bringing back a sense of belonging, because many of our Native youth and Native people, they've lost the sense of who they are. They've lost their sense of identity by systemic federal policy and intentional actions, have lost the sense of who they are, so they're kind of getting lost. They're getting lost. They're getting involved in gangs. They're getting involved in drugs. They're getting involved in alcoholism, and they forgot who they are. So some of the things we're doing, we're really bringing back the buffalo in southern Oklahoma, bringing back the horse culture, bringing back your sense of identity, sense of belonging, sense of who you are, and that's a real basic level thing, but it really delves into the social determinants of health greatly, and we're trying to do that, and hopefully we'll be successful. I can talk to you more about that but I want to give my panelists a chance to talk.
Yeah, thank you for that. Robyn, can you tell us what are some of the challenges and opportunities for tribal nations, Indian Health Service, and ITUs, and urban Indian clinics when it comes to collaborating with state healthcare systems?
Well, a lot of what you will find out and hear about in Indian country is that local as well as national legislators don't know anything about natives. They don't know anything about the policies. They don't know about treaty obligations. And so that has been a real challenge. So like I said, I serve as the president-elect on the National Council of Urban Indian Health, and I'm so thankful for that organization. We have a member here, and Meredith, wave to the crowd. Meredith works the Hill on behalf of the National Council of Urban Indian Health, as well as I spend a great deal of my time in DC. Even though I'm the CEO of an urban Indian organization here, I have 24,000 Native patients that I have to represent. And we are funded, our organization is funded at 27% of our level of need. So when you hear Indian Health Service is underfunded, urban Indian organizations are the least funded. So Indian Health wants to be funded at 55%. That's our goal. How shameful is that? That we as an agency want our goal to be 55% to take care of our people. Well, my organization's funded at 27%. So you want to talk about a barrier or a challenge, but instead of focusing on that, what I have to do is go out there and tell our story. So I tell our story about the way that we provide excellent health care to American Indians, because I think our legislators hear how broken Indian health is. They don't want to hear that. So what I try to do is tell them the positives, all of our health outcomes, because we know that we're the bottom of the barrel, but if you're going to get health care at the Oklahoma City Indian Clinic or across Indian Health, it's not a broken system, it's an underfunded system. So what we have to do is tell those stories to our legislators and tell them, you know what happens when it's funded at appropriate level? We have a remarkable outcomes. There's a bill that passed 20 years ago, the Special Diabetes Program for Indians. And because of that special allocation of money, we have seen remarkable outcomes in the realm around diabetes. So what we can do is tell Congress, look what happens when you fund us at a high level. We are good stewards with our money. So we do that at the national level. And so I would just urge any of you that are advocates or allies for whomever you're serving, and across the board, right? We're here to talk about health equity. We all have to be in this game. I can't work in a silo and just talk about Native health. That is my area, but I need to talk about all of us. We need access to care as people of color and marginalized communities, because no one else is speaking on our behalf, so we have to. So I just can't say enough about the advocacy work that needs to go on. Here in Oklahoma, we have a best practice model with our Oklahoma Healthcare Authority, which is Sooner Care. They have tribal consultation every other month. And I think that that's central to Oklahoma. I think that model needs to be spread far and wide, that Indian people are brought together at the policy level and with people that are decision makers. And so I'm really happy that we have that tribal consultation. And so if you want to learn more about that, I'm happy to share what that looks like with you so that maybe you could take it back to your community. But again, those are some of the things that I know that are working in Indian health.
Thank you for that. And I think that's a great point. Tribal consultation on a state and federal level is critically important, but not every state has a great relationship with their tribal community. I think it's few far in between in which that relationship is great. So tribes still have to provide health care. So whether it's looking at third-party revenue, whether it's looking at self-determination and contracting and compacting and taking on those services themselves, they have to get creative, they have to get innovative. But sometimes they can't go to the state or the federal government, or they refuse to provide their help. So they have to look at other partners. Estakio, can you talk about how Indigenous organizations are collaborating outside of state and federal partnerships to address health challenges? And what does that look like?
Thank you. Before I answer that question, I just want to thank my relative here for welcoming us here to his lands and for ensuring the safety of all of our well-being while we're here and for allowing this convening to take place. So often, you know, we failed in that very basic human test, right? You wouldn't dare show up to dinner empty-handed, even if the host told you that they don't need anything, right? You would at least bring a bottle of wine or something to show your appreciation. So I just want to say a huge tlasukamati and a thank you for hosting us here. So the Office of Strategic Partnerships was designed by Secretary Holland, and I'm very fortunate to be able to work under her leadership. The office has 3 areas of focus. One is Native-led conservation, the second is Native-led economic development, and the third is Native-led language revitalization. And so one of the biggest innovative pieces that we have been able to fund and has demonstrated tremendous success comes from our relatives up north in Canada, where they were able to fund language programs back for their youth. And in one village, they saw a 60% decrease in youth suicide rates by simply reintroducing language and cultural practices back to the community. 60%. You couldn't get those levels of accomplishments even if you trained 60 psychiatrists to somehow be culturally competent, move into these communities and provide their services, their best services. You still would not be able to reach those numbers, and it would cost you millions of dollars. But language programs do not cost that much money. And it's important for Native communities, for us, it's part of our identity formation when we're able to speak our language. I greeted you in both Yakima, Ichishkensinwit, and Nahuatlatoli in order to welcome all of my relatives to be here and join us for this conversation. What it also does is that it grounds me in the framing of each of those languages. And the best way that I can explain it is it's the difference, it's not just knowing a different word for sun and water, but it's the difference between thinking that you can look at a beautiful sunrise versus knowing that you're lucky the sun can look at you. It's a complete reframing that allows us to maintain our beautiful way of life. And when we do, when our communities are healthy and strong, ecosystems around us are also healthy and strong. And you know, we spoke a little bit about the history, but especially here in this Health Equity Summit, I think it's important for you all to know that there's a great reason to partner with Indian country. Our people used to, on average, our women lived to be about 140 years young. Our men, on average, lived to be about 120 years young. And that was, you know, it was hard at the beginning, right? Because we didn't have some of the advances that we have in pregnancy and maternal health care. But after you've made it past a certain age, we had the diets, we had the ecosystems, we had a very active lifestyle that allowed us to really be in relationship with the earth and to stay here to fulfill the mission that the Creator had sent us down here for. And so the biggest innovations that we have seen, and what I want to share with you all here, is in funding language revitalization programs. We have seen that if you want to tackle mental health and well-being for our young people and the next generation of Native people, you need to be funding language programs. Not only because of our own identity formation and the benefits that that creates, but also because embedded within our languages is a blueprint of knowledge that can help us address the challenges of present day and also those challenges that we have yet to experience. If any of you, and some of you have already mentioned that you go to Washington, D.C., if you ever get a chance to go to the Library of Congress, and you should, because it's a very beautiful library, and in there it houses, you know, some of the best knowledge and books that we have produced as a country. That library is the largest library in the world. And when we think of losing just one of our native languages that has been spoken for thousands of years and that belongs to the land, we think of 10 of those libraries of Congresses vanishing. That means that we are unable to tap into that resource for, again, present day challenges and those in the future. We know how to mitigate climate change and the risk of a changing world. You know, our communities are at the forefront of being inundated by the water. Our communities are being ravaged by fires, you know, and the country is now experiencing what we have already been experiencing for far too long. And if we're gonna have any of those solutions, we're going to need our language, because our language has that knowledge embedded. And so the innovation is around language revitalization. And then the other part, and you've already addressed this, is contracting. 105L leases allow and enable any tribal nation to create and to staff, like we could build a brand new hospital on native land today. And the minute that you hand over that certificate of occupancy to the federal government will take on those lease responsibilities because it is part of our federal trust responsibility with these nations. And so if we wanted to do something really innovative, we could go out right now and fund, you know, the building of new hospitals out in our communities where we know that healthcare is needed so desperately. And we could partner with Philanthropy to get that done, which is one of the projects that we are working on at the Office of Strategic Partnerships. Every time we do that, we see that ecosystems, the health of the ecosystems around our communities do well, and that's so important, not just for us, but for those people that live around us too, and their own health and well-being. But unfortunately, Philanthropy doesn't view Native country equally. You know, we are a very giving people, and even at our corporate level, there's corporate philanthropy that sponsors and gives dollars out and tries to make these investments with equity in mind. But for every $100 that are invested in philanthropy here in the United States, less than 4 cents are invested in Indian country. Not $4, not 40 cents. It's like 3.87 cents. That shows the real lack of investment in Indian country. And you know, the president has tried to mitigate this, which is why he issued Executive Order 14112, which was spoken about in a previous panel. But it shouldn't take an executive order to do some very basic human response.
Mm-hmm. Thank you for that. There was a lot of great points that you brought up there. I think one of the things to recognize, especially with the language revitalization, is that when we're thinking about what health equity means, health equity for Indigenous people is completely different. There's so many different elements that are involved. There's so many different Indigenous determinants of health that must be thought of when we're thinking of what health equity is. Language, for example, is one of those. The political status of tribal people is one of those. But also,
can I add on that? Because we're also, though we're less than 2% of the population here in the United States, we are caretakers of 80% of the biodiversity that still remains. That's because we know that our medicines are in the land and in the plants. And that's why we have special relationships with these. So it's, I think, in all of our best interest, because we don't know yet the diseases that will come in the future. But our ancestors told us to take care of this plant and take care of this land for a reason, right? And so I think it's in all of our best interest for the future cures that we're gonna need to really invest in Indian country.
Yep. It's also a great point. And I think you talked about really going outside of the normal pathways to engage in these different relationships with philanthropy, with other entities. Robyn, could you talk about some best pathways of building trust? Because a lot of times it's not that, you know, we just go out there. A lot of times there is broken trust between everyone else and tribal nations because of the history there. So what are some ways that other partners can build trust within tribal communities and with tribal people?
Well, I'll talk about what we've done at the Oklahoma City Indian Clinic that I'm really proud of, is we invite our partners to our clinic so that they can put faces with our stories. Instead of me just walking around at 23rd and Lincoln, which is where our state capitol is located, or going to DC. When National Congress is back in Oklahoma, I invite them every single time for them to come into our clinic and walk our halls with me so that they can see the people. So when I'm in their office, when I'm asking them to support a bill or asking for more funding, they can see the grandmas and the grandpas and the aunties because they have been inside of our clinic. And so I think it's really important to invite them in your home. Tell your story, but invite them in your home. Don't be afraid to bring them there. And at the local level, one of the things that we do is we have a strategic planning cycle every year. And we invite our community partners to come in and do part of a SWOT analysis. So just about a month ago, we had over 40 of our community partners come in and do a SWOT analysis. So we can show them what our 10-year plan is. We show them what our strategic goals are. We tell them that our vision is to be the national model for American Indian healthcare. We tell them that our mission, what we're in the business of, is to provide excellent healthcare to American Indians every day so that, again, that they feel a part of it. When you feel a part of something, you are more prone to support it and you understand it. So I would just urge people to invite people, when I say in your home, into your place of business. Let them know what you're about. Show them who you're serving and show them what you're doing because, again, it is so much easier. Once you've been in someone's home, you kind of get a feel for them, right? You know what they're about. Well, then invite them to your place. Show them how good that you are. It's such, amazing when they see, it's one thing for me to show them, well, look how many people we serve and how many medications we give and look how many diabetics look at these A1Cs that they've dropped from a 12 to a 9 and then they're to a 6. Okay, if you're a clinician, that's good. Or if you're a diabetic, you know what that means because you know those numbers. But when they see a grandmother with their grandchildren inside these diabetic education programs and then they see it in action, it's more meaningful. So I think that is certainly something that I would urge anyone when you are part of an organization, invite people in your home, invite them in your organization. Tell your story by showing them who you're serving.
Thank you for that. I think one of the things that Estakio mentioned as part of his answer was about traditional plants, traditional medicines, and how important it is to our people. Right now we're in a great time where CMS recently approved 4 1115 waivers, which would reimburse for traditional healing to be done in clinics by traditional healers. Dr. Kennedy, could you talk about how traditional medicine practices is being combined in conjunction with Western medicine to improve Indigenous health outcomes in communities?
Sure. So obviously, Native people were the first practitioners of the healing arts in these lands here. But if you look at practitioner numbers, we are a very, very small percentage of total practitioners. We're like point percentage of 1%, okay? We only have like maybe 300, 400 Native physicians in the entire country. And some of them have some knowledge. We do have, through the Association of American Physicians, we do cross-cultural medicine workshop where we bring in Native healers from other various tribes around so we can have our students and physicians learn some of the Native, and some of them were raised in these, some of them were raised on the res, and they do know some of these things, they were taught these things. But obviously they're very important. We're trying to raise our number of clinicians, but also incorporate traditional healing principles. And what's the best way to do that? We're not a pan-Indian group in the United States. We have 575 roughly recognized tribes. We're not all the same. We all have different healing principles, practices. We're all from different areas of the country, have different medicines, but traditional medicines have been important for a really long time, and pharma picked up on it a long time ago. You know, if you go into you have a heart attack right now, you go into the ER, what's the first thing they're going to give you when you walk in the door? Probably going to give you an aspirin, right? Natives have been giving willow bark for thousands of years, boiled in water, with someone have chest pain, okay? I've seen personally, I'm a Western trained physician, but I've been with traditional healers, and I was like a little skeptical, but I've seen firsthand, how someone with palpitations per se, and they're using, digitalized glycosides, and giving those for palpitations, or which is like digoxin, like a rate control medication. Or someone's got a toothache, you can walk up and pick a piece of echinacea and rip off the root, and I stick it between my tooth and gum, and my whole face goes numb. I'm like, holy cow, this is like, there's like real stuff here. So, and it makes me want to learn more. So I'll share with you something. My colleague Jim Warren, his brother, is a good friend of mine, Don Warren, and he is the head of the Indigenous program at Johns Hopkins. He's also a physician colleague, public health colleague. And we just, with Dr. Warren, debuted the idea and conceptualized the idea of starting an Indigenous School of Medicine here in the United States. There's only one medical school. Most medical schools in the United States don't have a single Native student in them. And we have about 75 or 80 medical students annually each year. And I think probably about 90% of those make it through medical school. And we have, I could talk all day about why we have so few medical students going into medicine, but that's another topic of conversation. But there's a medical school here in Oklahoma at Oklahoma State University in Tahlequah, and they are the first medical school to be for Indigenous students, and they only have about 30%, I think, maybe 35% Indigenous students there, because there's just not enough to really have a full medical school of Indigenous students. But it was primarily established in Tahlequah by Oklahoma State University in conjunction with the Cherokee Nation of Oklahoma to train physicians, young physicians, Native American physicians. But the problem with that is it's still subject to the Board of Regents for the Oklahoma State University and the governor and the legislature, okay? We would like to start a medical school, and you can go to the website. There's isom.org, and we have our nascent primordial soup of a website right now trying to talk about how we're going to do this, but we want to have a medical school that incorporates, it gives you the traditional MD degree, as well as incorporates traditional healing from various tribes from Alaska, from Hawaii, and various tribes from every region of the United States of America, where you incorporate medicinal ethnobotany, and the traditional ways that we've been doing these things for many, many years, and we still have the knowledge. And so this is a dream of ours, and we have to work with not only probably federal government, state governments, probably have to work with foundations. We need to get funded. It's really in the primordial soup right now coming up. But it'll be governed and taught by Natives, for Natives, with Native American faculty and all Native American students. So this is something that's being done. We're thinking about it. We're working on it. But it's going to take a lot to operationalize the idea. But I think the time has come. We have the first Americans, and there's just not really much been done in that area with the first Americans. And if we're not going to take control of our knowledge and hold on to it, then who will? So just wanted to share that with you. We're running out of time.
Well, I think we have a few minutes for questions.
Before we go to questions, I just want to say for everybody in here, there's like two things that you could walk away with, listening to this panel is, definitely we need the need for more funding for our urban relatives. There's what we see at the Office of Strategic Partnerships. We have a very unique bird's eye view of the ecosystems and the impact that they have in our communities. The lack of housing on reservations really make it hard for our communities to stay where they want to be. And so many of our relatives end up having to move to urban cities. And so this partnership and collaboration, we need to make sure that we're thinking in parallel ways to share resources with our relatives, both urban and those who are able to stay on the reservation. But two things that everyone in here can do to help us. One is fund urban health, and then fund this hospital that we really need to get, this medicine school that we need to get up and running. The reason is, there's still knowledge out there that we have not brought out publicly. Our elders, we're not as unwise as some of the history might say. There are pockets of knowledge that has remained secret and will only be shared in a setting like what Dr. Kennedy is trying to create. And it is in all of our best interest, because even consumers, I think, have now realized, the dangers of being on so many psychotropic or whatever medications. I think the public is asking for a reduction in this. You have to take one pill to wake up, one pill to go to sleep, and everything else in between. And so I think there's a calling for a more natural approach to addressing our illnesses. And that knowledge can only come out in a setting like what Dr. Kennedy is trying to create. And then the third thing that you can all do is acknowledge Indigenous Peoples Day. As a company, as a corporation, as a nonprofit, whatever you lead, acknowledge a very basic fundamental truth, that there were other people here first.
I have two quick questions, one for Robyn and one for Dr. Kennedy. So Dr. Kennedy, if you have a position in White House, what would be your plan to address these so many Native American health problems? So
Very
later, just 1 sec. For Robyn, real quick. So I'm actually very surprised that you have 27% funding from Congress, right? Congressional appropriation. As we were doing academic study about IHS underfunding, we looked at IHS congressional budget sheet, and we saw that about 1% of the congressional appropriation has been budgeted for the urban facilities. So, and we tried to figure out whether its president cut that budget for youth facilities, or it's a tribe budgetary formulation work group themselves proposed a lower percentage. And it turns out that the tribe work group themselves proposed less than 2% of IHS budget to be allocated to youth facilities. So I wonder how, if that is true, which is true because we've already figured out the numbers. So I was wondering what would be your solution to that, because we heard that you have done an amazing job to fundraising in Oklahoma. So I was wondering, like, how much do you think that financial model could be expanded to all the youth facilities nationwide? Thank you.
Do you want to go first?
I'll go first.
Okay, go ahead.
Then you can ponder. But 80% of American Indians live off reservation. And it's true what my brother said here. A lot of it is because reservation life, you had to move off to support it. That's how I ended up in an urban area. I grew up on the Cherokee Reservation. Like I said, my family is still there. Went to the University of Oklahoma for an education, and then was an Indian Health Service scholar. So for every year that they paid for my education, then I ended up working for Indian Health. Thought I was going to do 2 years in Indian Health, and 29 years later, here I am. They can't kick me out the door because I love it, right? The reason why we all do budget formulation, each of the 12 Indian Health areas do budget formulation, but there is this much dollars for this many people, right? And so we're all going to go to budget formulation and advocate for our people. And tribes are sovereign governments. And so they have special legislation where they can do joint ventures, meaning that they can front the money for the organization, build the building, and then Indian Health will provide for them to have the workforce. Urban Indian organizations do not get that. So there's legislation that Indian Health has and that federal facilities have and the tribal sides have, but urban Indian organizations do not. We are just now doing a lot of policy work to get caught up. So I think that historically we're underfunded because we weren't always at the table. We're starting to get there now. That's why you're starting to see the urban line item get higher. The reason why Tulsa, there's an urban clinic in Tulsa as well. You may see that our numbers are a little higher when you're doing your research, and the reason is, I told you I spent a lot of time in D.C. Well, when you spend a lot of time in D.C., you get to do a lot of ask. Unfortunately, we've had some that have benefited our sister clinic in Tulsa as well. We have special legislation that we are to be treated like a service unit. So we get funded at a higher level, and that, again, was because of the relationship we built with congressional staff. We said, we'll set us up like a demonstration project, and so fund us like we are a service unit, and they did, and then we got special appropriations that says that we would be funded at that level forever as a service unit in the Affordable Care Act. So we are, that's why Oklahoma City is different. And that's why you'll see more robust services there. What we want to do is spread that across the other 39 urban programs because so many Native people live off reservations. So I hope that that answers your question as to kind of the funding source and how it's, why urban Indians are funded at a lower level. And it's through history. And then if there have been times that some administrations have tried to zero out the urban Indian line item. I won't point fingers to what party that is, but I'll let you guess. But there's been a lot of administrations previously that have tried to zero out urban Indians as line item again. So we've had to work and scrap, and again, because what do you want to do? As what we've heard all day in these panels is, if you're not in front of Congress, they'll forget about you. And so again, we have to stay in front of them.
Thank you, Robyn. And I want to thank Dr. June Zhao for that question. Stand up, June. Dr. June Zhao is a health economist and a public health researcher at the University of Oklahoma, who I collaborate with. I mentioned I have a lot of hats, so one of my hats is public health researcher. So we're working together on some immunization work in Indian country here in Oklahoma, and we've got a multi-million-dollar NIH grant application pending at the moment, so fingers crossed. So anyway, she asked something about, okay, if you were somewhere close to the White House, what would you do to try to help with the situation? And thought a little bit about that question, and there's a old quote from John F. Kennedy that said, "Everyone can make a difference, and everyone should try." And that's kind of profound, because we're all just one person. There's only so much you can do as one person, but you can actually have a profound impact. So being a physician was my first job, being a good physician, being a good doctor, taking good care of my patients competently, not just medically competently, but culturally competently as well. And then got into public health and trying to do all these things with natives. But if you got in the White House, you really have to bring all that to fore. If you were working with or for the president, like Secretary Haaland, you really have to understand your people on a very granular level. So it's really hard you have to be involved at a very tribal level, a very community level. Someone said earlier, all politics is local. You really need to be tuned in what's going on locally, in your own community, in your own state, and then be able to take that to DC. And I've been to Congress. I've been in the halls of all the health and human services agencies in Washington, D.C. I know how those wheels all work. So I thought about, gosh, I go up there and talk to congressmen, I talk to this senator, that senator. We've had very few natives up there. I was like, where are all the skins, man? Where are all the natives that are up here, working in Congress? There's not many. We've had Ben Nighthorse Campbell. We had a very few Native American senators. We finally have our first Native American cabinet secretary. We've never had a Native American vice president or president. And hopefully that'll happen one day. But I thought, if you could get close to the president, what would you tell him? So I actually did think about that. So I actually applied for the White House Fellowship a few years ago, and I was national finalist 2 years in a row, and I'll be applying at least one more time. But I thought about, what if you could get in the room with somebody and actually talk to them and try to convince them that this is actually an important thing that's been overlooked and overlooked and overlooked and kicked down the road for year after year, decade after decade, generation after generation. So hopefully I will be able to do some work along those avenues, but I kind of avoided the previous administration. There's a guy with some really bad hair that is not a friend to Indian country, and I like to call him public enema number one, like to flush him. So anyway, I think it depends on the administration, depends on the whose ear you're talking to. If you can get the ear of whoever's in the White House or whoever's in the cabinet, and just start getting your stories told. Because we need data, of course, but stories really do compel people to move. And if you have really good stories and really real images that they can seize upon and use that in their policy, I think we can really do some good work. So I'm only one person, but I put out a call to action to people of all colors. It doesn't matter who you are. If you can help with this and join us in this cause to help Natives move forward, because there's a lot that's not been done over the years, and we're trying to correct some of the wrongs that's been done over the years. So, thank you.
And to kind of go a little bit off of that, when it comes to the budget piece, President Biden was the first to ever actually propose a budget that would potentially fully fund Indian health. Unfortunately, one of the biggest challenges is the number that the budget formulation, which is a group of regional representatives that come together to essentially determine how the budget is allocated across Indian health. It is very much done in a guesstimation type of way. There is no actual, economic study into what it actually would cost to fund Indian health and where the need is to fund it. The National Indian Health Board has been trying to partner with Mathematica and Robert Wood Johnson Foundation to really determine what that need is. Because when you go to Congress to ask for full funding for Indian health, there's no real methodology behind it, right? That goes to the line item for urban Indian programs, right? How can we really justify that line item when we don't have anything, and how can the urban clinics really go to bat for that against the tribes and with that small pot of funding? So I think one of the biggest things is really to help understand that and to advocate for that and to really push that through Congress as mandatory funding for Indian health system. But that is all the time that we have. Thank you to all of our panelists, and thank you to everyone for being here today.
Do you want to share the news that you shared with us a little while ago about what's going to be the announcement tomorrow?
Oh yeah, I'm not sure if folks saw, but the recent article came out in the Washington Post. President Biden is planning on issuing a public apology for the boarding schools tomorrow or sometime this week, which is very historic, so we're super excited to see that.